I'm Katie Brown, and I was diagnosed with breast cancer 8 years ago, and so I'm an 8-year survivor, which is really cool. When I got my diagnosis, I was mid-40s, and it was a complete shock to me. I just knew that they had mixed up the tests with someone else, because I just never thought that this would happen to me. One of the options that I had was a lumpectomy and radiation, and the word radiation at first just scared me to death. I made an appointment and went to, it was Dr. Stilley, and when I pulled up in the parking lot out in front, before I ever walked in the door, I lost it. And I looked at my husband and said, I shouldn't be here. This is not where I'm supposed to be, and I don't want to go. And he said, okay, you don't have to go in here. But he said, they are giving you a chance to live, and if you don't want to do this, I want you to do it for me, because I want you to live. Went in and met with Dr. Stilley, and he was so kind, so patient. He answered my questions, and one of my biggest ones was, I thought radiation killed you. I mean, I thought it was bad, and he explained the difference in radiation types. He explained the process of what I would go through. He answered my questions, answered my husband's questions, and I agreed and decided to go through with radiation therapy. The following week, when I went back, it was very welcoming when I walked in, which was great, because I was actually shaking. Their goal was just that I was safe and in an environment of people that were doing the best for me.
If there's anything we can do to make your journey through our department more comfortable, please just ask.
We want your experience here to be as comfortable as we can make it. We want to make you feel like family.
Hi, I'm Stephanie, and I'm the social worker here at Radiation Oncology. A cancer diagnosis can be a daunting experience, and it's different for everybody. My job here is to get to know you and see how I can help meet your needs. My role here is to help support you through this journey. I can provide counseling, I can provide emotional support for you and your loved ones, I can offer you a link to community resources that perhaps you're not familiar with. And I'm also here just to talk about your day-to-day needs. If you are traveling from out of town, some of the options that I can provide are local hotels or an apartment nearby to help create that home away from home environment for you while you're going through this process. I know that cancer can be scary for many of our patients, but you don't have to go at it alone. I am here to help you, and I'm also here to help restore hope.
My role as radiation oncologist is to first determine if the patient is appropriate for radiation therapy. In other words, if our treatment modality can help in the treatment of that patient's tumor. Once that's been determined, then the next step is simulation. We have our own CAT scanner that we use for that. Usually we have people lying on their back. We'll put marks on them, take measurements. The whole process takes usually 30 minutes to an hour at the most. We also will occasionally replace the marks with tattoos, and they're real tattoos, but just dots like freckles, and we may put 2 or 3 of those on. Now, the computer planning can take us some time, and by some time I mean even as long as a week or 2 weeks. Of course, the patient doesn't have to be there for that, but once we determine the best treatment course, then we're ready to go. The treatments themselves are short. Most patients are in and out within 10 or 15 minutes. We treat every day, Monday through Friday. Don't treat on weekends, don't treat on holidays. What that means is a short break in the treatment's not a problem. So you miss a day here, you miss a day there, it's no big deal. The important thing is we get the total number of treatments in. At this facility, we have IMRT and IGRT. IMRT is intensity modulated radiation therapy, which is simply improvements in the machinery and the computer hardware and software such that we're able to deliver very high doses to very small targets. The IGRT part is image-guided radiation therapy, and that's a targeting system. What that means is that, bottom line, we're able to treat people better. We're able to give higher doses of radiation to the cancer and smaller doses to normal tissue that we don't want to give radiation to. The way radiation works is by doing damage to the DNA in the cancer cells. Now, usually that's not enough damage to kill those cancer cells outright, but it's a little bit of damage that keeps building up day after day, and that's why we give small doses of radiation spread out over many days of treatment. Normal tissue has good repair mechanisms, so if we treat you today, by the time we treat you tomorrow, most normal tissue has had time to repair. Cancerous tissues tends not to have those kinds of repair mechanisms, so that damage just tends to build and build. Radiation has changed a great deal in the past 20, 30 years. The chemotherapy gets better, which many times means that we don't deliver the amount of radiation that we used to. We also may be treating smaller fields. Also, the imaging has gotten much better. In the past, we might have just simple chest x-ray to try to set up a treatment field, and we might end up treating a very large area that really didn't need to be treated. With the CT scans, the MRI scans, the PET scans, there are just so many improvements, and we're able to pinpoint locations much, much better than we used to. Add to that the ability of our machines to hit those targets and deliver really high doses to really small targets, low doses of radiation to normal tissue. It all adds up to far, far improved therapy than it used to be many years ago.
Hi, my name is Carrie Thompson, and I am a radiation oncology nurse practitioner. I will be seeing you during your initial visit. At that time, I will be reviewing all of your medical records to make sure that they are complete and accurate. I will be performing a comprehensive physical exam, and then we'll be seeing you in collaboration with Dr. Stilley to formulate a treatment plan. After your new patient visit, when you have completed your dosimetry, I will be reviewing that during a detailed patient and family education session so that you are well prepared to take care of yourself while you are undergoing radiation treatment. I will be available to you while you're on treatment to assist you with any symptom management questions that you may have. Because I am an advanced practice nurse, I am able to examine you, make diagnoses, and prescribe medications as needed. When you have completed your treatment, you will be meeting with me to review any specific discharge instructions so that you are prepared to take care of yourself when you are at home and no longer receiving any radiation treatment. I will be seeing you in follow-up in approximately 1 month, as well as 4 months after the completion of your treatment, to make sure that you are not experiencing any untoward or late effects from the therapy that we have given you. At that time, I may also order any diagnostic studies that may include an MRI, CAT scan, or a PET scan to evaluate how you have responded to your therapy. We appreciate that this can be a very difficult time for both you and your family, and we would like you to know that all of the team is very skilled in taking care of any of your emotional and physical needs while you're receiving therapy.
Hi, my name is Betty Munoz, and I'm a certified medical dosimetrist and a registered radiation therapist. My job is to take your x-ray exams and Dr. Stilley's prescription for your treatment and use all of the tools and radiation beams that we have available here to design a treatment plan that matches your body and your tumor. If you have a complex tumor or something that we have to coordinate with chemotherapy, we want to be able to give you the best design that's going to give the best effect on your tumor without harming the normal tissues in your body. Here's an example of how I use a PET CT to define the tumor volume that Dr. Stilley wants me to treat, as well as the other normal tissues that happen to be in this area of the body. The PET CT is a radioactive sugar that is picked up in the tumor and lights up on the CAT scan. And here's an example of cancer of the rectum that we're going to be treating, not only the rectum, but the surrounding lymph nodes that drain that area. This is an area where tumors like to travel to when they spread. This PET CT also shows me the other anatomy that I want to be able to outline so that I can avoid it when I design the radiation treatment. Here is a sample of where the patient's bladder is. Here are the patient's hips. Here is the patient's small bowel. And this is lymph node area that Dr. Stilley will want us to treat. And so through the area of the pelvis where the rectum lies and the lymph nodes that drain it lie, I have all kinds of contours that will show me where I need to avoid putting radiation and where I need to focus the radiation. This allows me to see how the different organs of the body are situated in your anatomy. And then when I put my radiation beams on, I can see how my radiation distribution is avoiding some of the structures that I don't want to give a lot of treatment to. Small bowel and bladder are areas that we don't want to give a lot of treatment to so that you don't have long-term problems down the road. Every patient, after they get their first treatment, will have a visit with our radiation therapy nurse practitioner, and she will be having samples of your treatment plan and will explain to you exactly how the radiation that we've designed for your treatment is interacting with your body. So you will be getting something like this when you get your education from our radiation therapy nurse.
Hello, my name is Mark Skorchuk, and I work as a medical physicist at the Kalispell Regional Medical Center Cancer Center. I work largely behind the scenes with various treatment planning computers and different quality assurance measurement devices with the goal of ensuring optimal treatment design and equipment performance. I work directly with Dr. Stilley and Betty, our dosimetrist, and our team of therapists, nurses, and office staff to ensure that you receive the best possible care. Each member of the team is committed to that purpose. IMRT is different from three-dimensional conformal radiation therapy in that with IMRT we use sophisticated computer planning systems to calculate the optimal way to simultaneously deliver the prescribed treatment while minimizing the dose to the surrounding normal healthy tissues. Modern linear accelerators are equipped with a treatment delivery device called a multi-leaf collimator, or MLC. The MLC is a device that creates the shape of the treatment portal through which the radiation is allowed to pass. The MLC stays open longer over the parts of the treatment area that are to receive more dose, and actually stays closed or open for a shorter time over the areas that we're trying to protect. Since the dose is delivered from several different angles as the gantry moves to different treatment positions around the patient, IMRT breaks up the dose among the different positions to selectively reduce the normal tissue dose and give the tumor the full dose that is prescribed. As a medical physicist, I'm involved in both designing the treatment and in verifying the accuracy of the treatment to ensure safety for the patient. All of this is done to ensure that the Cancer Center at KRMC is a regional center of national caliber.
Hello, my name is Quinn, and I'm one of the radiation therapists here in the department. If it is determined that you need to have radiation therapy, your first step will be to go to the simulator. This particular simulator is a CT scanner also. This is the room where we'll make all the immobilization devices. We will set you up in a position that we can reproduce on a daily basis for all of your treatments. One of the mobilization devices we use for the pelvic area and lower extremities is called a vac lock. This is actually a large beanbag chair, or beanbag, filled with styrofoam. When we suck the air out of it, it gets very rigid. Each day you would come in for your treatment, we'd slide your legs back into this so we know that your lower extremities and your pelvis are in the same position. This next immobilization type device is called a breastboard. If you would be receiving radiation to the breast, we would lay you on this and we'll bring both arms up above, out of the way, and we'll do all that on this flat surface of this table. If you're treated to the area of the chest or the lung area, we would use a device like this called a wing board, and we would have you lay down on the table and your head would fit into this, and we have lots of different head holders to fit you, so we'll find one that fits. And then you'd bring both of your arms up and grab those pegs, and that keeps your arms out of the way for all of your treatment. So the next immobilization device we use is for the area of the shoulders, the head, and the neck. This is a thermoplastic material that when heated in water gets very pliable. It starts out like this, then we literally take this and we drape it down over you. This would be one that would be treated to the head area, and then it clicks into the table and it cools very rapidly. Within 5 minutes this becomes very rigid again, and we have an exact outline of your head. This one would be done to do the whole head and the shoulder area. So we would take this, and once it cools and all the scanning is done in the simulator, then each day for your treatment we'll slip this back on and we'll know your head is in the exact position it needs to be for all of your treatments, which allows us to treat as accurately as possible to just the area that Dr. Stille has prescribed his treatment to go. Once we have you in a position that we think you can reproduce every day, you can lay down the same way, then we do a CT scan, and that all happens through this area. This is an X-ray tube that rotates around you very quickly, and it allows us to gain a three-dimensional image of you, and our dosimetry department at that point is able to determine what the exact treatment plan is specifically designed for you and everything that's going on inside you. And that's what simulation is. It's simulating how you're going to get your treatment.
Hi, I'm Patrick, and I'm one of the radiation therapists here at Kalispell Regional. And this is Jenny. She's also a radiation therapist here. And this is where we're going to be at when we're doing our job and administering your radiation treatments. You're going to be on the other side of this wall in the treatment room. Once we get you all lined up and set up on the table, we're going to come back out here and do our job from here. So we have 4 cameras in the room that we can see you on. There's an intercom that we can hear you on. So even though we're out here, we're still in contact with you and watching and making sure you don't move. When we give you your treatment each day, there's always 2 of us working together. We have our scheduling computer. We have our computer that runs the multi-leaf collimation and the onboard imager, and the actual computer that runs the linear accelerator and the monitors that we can see on in the treatment room.
This is our treatment table. We're going to set you up just like how they had you on the CT simulator or the PET scanner. We're going to raise you up underneath the machine here. The table's going to come up underneath. Patrick and I are going to work together to move you and line you up to those marks. All right. Looks good. There's going to be 2 arms that come out on either side, and we're going to take some x-ray pictures with those and get you in the right position. You just hold nice and still and breathe normally. You won't see or feel anything. There's a little light that comes on when the radiation's actually on. It's a light over here in the corner. And we're watching you at all times, so if you need anything, we can come right in. If you cough, we'll come back in and check your setup as well. The machine can rotate around you 360 degrees, so we can treat you from various angles. You're going to feel the table move a little bit, and then we'll begin your treatment. Okay.
Once we've completed your treatment, one of us will come into the room and get you back down off the table and send you on your way.
My husband went with me to my last one, and he and I sat out and cried in the parking lot together, and it was such a different feeling than that being afraid going in that first time to the time when I was done and thinking, you know, I made it through, and I made it through with a support group that were just incredible. I can say from the bottom of my heart, you're with people that care about you. You're with people that want you to survive. They want you to beat this, and they will do whatever it takes to help you accomplish this. So you are in such loving, compassionate hands, and people that they know what they're doing. They want you to survive. So your best interest is at the center of what they're doing.